So next, before we can enjoy lunch together, we have one more speaker, Dr. Morgan DiLeo. She's an assistant professor of ophthalmology, bioengineering, and clinical and translational science at the University of Pittsburgh. Welcome back.
Hi, everyone. Thank you so much for having me back. It's always such a pleasure to be here. Honestly, that was the best possible talk to precede this talk. Now you are all experts in ocular anatomy, in ophthalmology, in corneal cystinosis, so I can just skip over all of that. I'm going to be talking to you today about drug delivery. This is what my lab works on. Drug delivery just means that we take usually FDA-approved drugs, things that already exist, and we repackage them in a way to make them either safer or more effective, or hopefully both. And that's what I'm going to talk to you about today. You'll hear some terminology. I may describe things like the positive control, the negative control, the test group. When I'm talking positive control, those are those Cysteamine drops given at a normal schedule that you would expect for what's prescribed. The negative control, that's the same materials that we use in my lab, but with no drug at all. And then the test group, that is going to be our spray-dried cysteamine microspheres, which is a mouthful. We call it solid drop for short. And anytime you see a box with the green text or the green box with black text, that's going to be one of the key conclusions. I want to really zero in on that. So why this exists as a field, why we do drug delivery research, is because when it comes to eye drops, as you just heard, there's this need for really frequent re-administration of drops. The reason is that so much of it is wasted, and so you administer an eye drop, most of it is lost, you have to re-administer the eye drop, and at all times you're kind of hovering either above or below where you really want to be in terms of drug concentration. If you have too much, you might experience some side effects. If you have not enough, you're not properly treating your disease. What we aim to do is something called controlled release, which is exactly as it sounds. We aim to control the presentation of drug so that you have just the right amount for very long periods of time, which eliminates the need for that really frequent re-administration. And the technology that my lab works on in particular is called solid drop, which is a controlled release eye drop. So this is a topical, non-invasive formulation that someone can administer in their own eye. It is a liquid drop that at body temperature in the space beneath your lower eyelid turns into this soft, pliable gel depot. It has these drug-loaded microspheres in it that slowly degrade over time and release that cysteamine to the ocular surface. This is the cysteamine microsphere, the gel, and then the suspension of the two mixed together. You can see here a video of the drop going in a rabbit eye, and then the drop being flushed out of that same eye. After installation, you can see how it turns into that soft depot. After removal, there's nothing left behind. You can remove it using clean fingers, although I would recommend a cotton swab or saline. That's how we do our studies. It doesn't interfere with the cornea. There's no involvement of the cornea at all, so it's very different from a contact lens and wouldn't interfere with that. And it remains in that soft gel state at a wide range of ambient temperatures. So here's a look at how long this actually stays put. This was a study we did for glaucoma medication. We've shown that this can be effective and safe for treating glaucoma, infection, inflammation, dry eye, lots of different things here, but what we're here to focus on is treating corneal cystinosis. As we just heard, and as all of you know much better than I do, you need this really high concentration that can be very irritating to the ocular surface. There's a need for really frequent re-administration of those drops, right? Once every waking hour is bonkers. And then there are these storage issues, right? The stability of the drug is so terrible that you have to really be mindful of how you store them. And all of this is very cumbersome and problematic when it comes to compliance. Fortunately, that's exactly the type of thing that controlled release technology aims to address, right? We have these drug-loaded microspheres that give you lots of drug over a controlled amount of time so you don't need to re-administer it. So what we've shown with CRF funding over the years is that we can get 24 hours of release, shown in this data here and in this publication. We've shown that it's very stable, at least 7 times more stable in refrigeration than the Cysteamine eye drops. We've shown in multiple ways that it is safe. It doesn't irritate the conjunctiva, which we just learned about. It doesn't irritate the cornea. This is very important. It can be sterilized and stored contaminant-free. And we've shown that it does actually deliver the right amount of drug. So we look at efficacy two ways. We look at how much drug is in the cornea and what is the effect on crystal density. When it comes to how much drug is in the cornea, we did this testing using rabbits. We did a biodistribution study, and the key comparison here was our test group, which was a single solid drop, one drop administered at the beginning of the day, nothing else for the rest of the day, versus 12 Cysteamine eye drops. So a 12-to-1 ratio. And what we see here, this is the biodistribution data, which I will kind of walk you through. The red squares, that's the 12 drops of Cysteamine. And you can see that there is a pretty high concentration, and that makes sense because every drop is a spike in concentration. But imagine that that is getting flushed out, so that spike immediately drops to basically zero. So when you see that 12-hour time point in the cornea, it drops to zero right after that. So at 24 hours, no drug has been present in the cornea for that entire period of time. Whereas with those blue triangles that are somewhat hard to see, we do see a lower concentration, but remember, that is continuously being presented. So what matters here, and I also want to point out, I like looking at how the drug moves into the eye as a front. You just heard about how retina is also involved when it comes to cystinosis, and it's important to note that this drug is penetrating all the way through the eye. So you can see it starts at cornea, it moves into aqueous humor, and then it even gets into vitreous humor, which is a lot of movement for drug to get through many tissues in your eye. That's actually quite hard to do, and we see at 24 hours that there's drug present in vitreous humor, which is remarkable. And what's important, again, no drops between 12 and 24 hours. If you take a look at this, this is my roughly drawn sketch of how to interpret these data. So those spikes with each eye drop, yes, you get a lot. You don't necessarily want a ton of drug. You want the right amount, but not too much. And then it drops to zero. Whereas with the controlled release, we see what matters is the area under the curve. And if you compare those two, it suggests that there's enough drug over 24 hours with that single drop. So the last thing to show is what's the effect on crystal density. I'm trying to be mindful of time. I know I'm standing between you and lunch. So we tested this in a mouse model, and we do this using imaging. You just heard, again, amazing intro, about optical coherence tomography, which is an imaging method. It is non-invasive, and we're able to look at essentially the pixel intensity on the cornea, which tells us how many of those cystine crystals are present. And we do comparisons between our cystinosis mice and our wild-type mice. One of the problems we've struggled with is how do you get this teeny tiny drop in this teeny tiny eye? It's really hard because of mouse ocular anatomy, and we struggled with that a lot. We ended up testing a method where we used an Elizabethan collar, right? If you have a dog, the cone of shame. And you put a little bit of film over the eye, and this is how we keep it for the duration of the study. We did this, we saw at 1 week that we were seeing a slight drop in our positive control, the Cysteamine drops, in terms of pixel intensity, which we relate back to cystine crystals. And then we saw in our test group it was about the same, right? It was a good trend that we expected to see continue. Unfortunately, it did not continue. We actually saw pixel intensity going up in our test group, which was unexpected. When we looked at the eyes themselves, we see that yes, pixel intensity is increasing, but more noticeable than that is that the thickness of the cornea is increasing. This is not what you want, and it was really discouraging. And it turns out that what was happening here is that we had to keep the mice under these heat lamps to keep the gel transitioned while we were administering it. That heat being blasted on their faces, along with the fact that they couldn't groom themselves, led to this opacification, this thickening of the cornea due to a lot of dry eye. So since then, we've shifted to these thin films, same materials, we just dehydrate them, place them in the eyelid, and walk away, and it transitions on its own, no need for the heat lamp. The other thing we've done to facilitate better interpretation of these results is we've done some new image processing. I won't really belabor this point, but before what we had to do was analyze 100 images per cornea, so every single mouse, 2 corneas. You can imagine this gets to be a lot, and we had to if you look at this, so we had to determine the region of interest manually for every one of those images. Now what we do is we flatten the cornea, and we have a computer script that actually does the region of interest for us and does the analysis for us, so it is much faster, and we're seeing the same comparable results here. The last thing I'll mention, though, is that if it's stable, that's great. If it's safe, that's great. If it works, that's great. But it doesn't mean that it's actually something that patients can use. And for that, we've done some more testing with pinch force. So pinch force is how hard you have to squeeze a bottle to get a drop out. And this is something that actually was not at all on my radar. I only became familiar with this through interfacing with all of you here at CRF. That these bottles are just really hard to squeeze to get a drop out of, especially that thicker Cystadrops solution, right? So what we did was we took both types. We actually got some shipments of Cystadrops from some of you, which was so incredibly helpful. We emptied out those bottles. We filled it with our material. We filled it with water. We did comparisons of water Cystadrops and solid drop in regular eyedropper bottles and Cystadrops bottles. And what we found is that our gel is too viscous. The pinch force required is just far too high, regardless of the type of dropper that we use. The Cystadrops bottle does actually bring the pinch force down, but it's still not acceptable. So what we did there is we lowered the concentration, which lowers the viscosity, which means less pinch force is required to squeeze out a drop. And what we see is that we can get it actually in the range of just water without affecting the key properties of the solid drop that give us the controlled release that we need. Last thing, we also spent some time in the past year working towards some translational progress. And one of the key findings here is that people we spoke to, potential investors or partners, said, what about this mixing before you use it, right? The microspheres are degradable in water. The gel has water in it. When you mix them, that begins that degradation process. You get that drug release starting the moment you mix it. It's a lot to ask to have to mix this up just prior to use. So what we've done now, rather than doing this suspension that's prepared the moment you go to use it, we're looking into some alternative approaches, one of which is that thin film, the dehydrated materials, same exact materials, same use, except it's a thin film instead. We've also begun to package these metal organic frameworks, which sounds weird, putting metal in your eyes, but these are amazing drug carriers that are stable in water. They do not degrade in deionized water, so they can sit there shelf stable in the solid drop material without releasing any drug, and then once you put them in the eye, that's when it would trigger that drug release. And you get amazing drug loading with this, so those are really promising. And we've also started to look at some liposomes. This is actually done with my postdoc, Dr. Sin Fan, who was funded through CRF through one of the fellowships, and he's been packaging these liposomes, which, similar to the MOFs, are the metal organic frameworks. Those are stable in water. They don't degrade the same way like the PLGA that we use currently, so that is promising as well. So I will wrap up. I want to thank everyone who's participated. I want to primarily thank CRF. Your support has been really critical in the success of these studies. And this is a picture of our brand new building here, which we moved over the past year, and that was that ate up a lot of bandwidth for sure, but there it is. So thank you so much.
Thank you, Dr. DiLeo. We have time for a couple questions. Does anybody have? Okay, thank you.